Good afternoon, everyone. Happy Friday to each of you. There are a few people still coming in, so I'm going to give it just a moment before we get started. All right, looks like the majority of the waiting room has joined. So, good afternoon, everyone. My name is Robert Hersey. Happy Friday to each of you. And on behalf of FATA, welcome to today's webinar titled Seniors and Behavioral Health Challenges. This webinar is being made available through a collaboration between the Florida Department of Children and Families and FATA. Please note that as an attendee, you are in listen-only mode and are only able to view your name. Your webcam and microphone have been disabled. If you have questions, please send them using the chat panel as you think of them. We will track questions and answer them as time permits. Our audio is broadcast through the internet to your computer. If you experience poor computer audio at any time during today's presentation, there are a few options to try using the audio connection panel. For computer audio, click the up arrow next to Audio Settings, click Leave Computer Audio, click Join Audio, click Join with Computer Audio, and follow the instructions. If you continue to experience poor audio through your computer, try calling into the presentation. Instructions are on your screen and will be posted in the chat panel momentarily. You must be connected to the audio of this presentation and view it on screen to receive a certificate. We cannot verify attendance if you are not connected to Zoom through the website, desktop application, or mobile application. Therefore, call-in only attendees are not eligible for a certificate of attendance or CEUs. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording and PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on Training Library as shown on the screen. A certificate of attendance and CEUs for up to 2 continuing education credits are available for participating in today's webinar. CEUs are available for individuals licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, Mental Health Counseling, and for those credentialed through the Florida Certification Board. To receive a certificate in CEUs, you must attend the entire webinar. Zoom provides a report of the arrival and departure times of attendees. We are not permitted to provide partial credit. You must also complete the post-webinar evaluation. The evaluation will close on Wednesday, March 4th, 2026. Certificates will be distributed within 30 business days after the evaluation closes. CEUs will be posted within the same time frame. FATA has implemented operational changes to our webinars based on the feedback of our attendees. Below are a few important changes. Evaluations will now take place in Zoom immediately after the webinar. Certificates will now be emailed to you directly. You no longer need to sign into your FATA account to complete evaluations. For all webinars and workshops November 2025 and later, certificates will be emailed to you directly. For webinars and workshops before November 2025, certificates are still accessible through your FATA account. Please note, using someone else's registration link to join this webinar is not permitted. If you are currently logged in under another person's link, you must log off and register at www.fata.org to receive credit. If you previously registered but no longer have your link, Zoom will allow you to re-register using the same information you initially provided. Attendees who do not join through their own unique registration link will not have their attendance recorded and will not be eligible to receive a certificate or CEUs. This presentation is intended solely for educational purposes. The views, opinions, information, and content expressed in the presentation are those of the presenter and do not necessarily reflect the views, opinions, or policies of the state of Florida, the Florida Department of Children and Families, FATA, or the Florida Behavioral Health Association. Attendees should note that sessions are recorded and published in various media. Our presenter today is Dr. Christine Cauffield. Dr. Cauffield, CEO of LSF Health Systems, currently oversees the managing entity comprised of 100 behavioral healthcare organizations in Florida's Northeast region. She has led organizations providing integrated health services for children through seniors, including a corporation that provides inpatient, acute psychiatric care to seniors in crisis. Dr. Caulfield received her doctorate degree in clinical psychology from Florida Institute of Technology and completed her internship and postdoctoral residency at Harvard Medical School, where she specialized in geriatric neuropsychology. Her clinical expertise includes substance abuse, trauma recovery, grief and loss issues, integrated health, and brain disease disorders in the elderly. She was previously a governor appointee on the State of Florida Substance Abuse and Mental Health Commission and is a co-chair of Florida's Optimal Aging and Mental Health Board. She also serves on the executive committees of the Florida Council on Aging, Brain Injury Association of Florida, and Smart Justice of Florida. And now I would like to welcome our presenter, Dr. Christine Cauffield. Dr. Cauffield, I will turn it over to you.
Oh, thank you so much, Robert. And I really appreciate this opportunity. Thank you, FATA. Thank you, Department of Children and Families. And a big shout out to Robert as well. He's really done a great job of coordinating this, and I appreciate all your help. And I appreciate all of you joining us today. This is a subject that's near and dear to my heart, and I hope that at the end of the session, you're going to be able to walk away with some more tools in your toolkit to be able to understand and work effectively with your senior clients. So some of our learning objectives today, three of them are identify key symptoms of cognitive impairment in senior adults, define reasons older adults develop prescription medication misuse, and explain the health consequences of the loneliness epidemic that we have in this country. So, who are our older adults? Well, according to 2000 census, 12.4% of all Americans were age 65 or older. However, we're rapidly approaching 2030 now, only 4 more years to go. The number of older adults will and have doubled to 70 million, or one in every five Americans. So you're going to see more and more of senior clients having issues and hopefully coming in for treatment. So think about it. In 1940, if you lived to the ripe old age of 65, it was anticipated that you'd live another 12 and a half years. So 77 and a half years old. And today, with our medical marvels and wonderful interventions and the advances, we are now anticipated to live 17 and a half more years should we reach 65 years old. So we're aging, we're getting older, and medical advances are keeping us alive. And some would argue, is that a good thing or not? And that's a whole different webinar. All right. So the key issues that we find in dealing with our senior clients are depression that they struggle with, suicide, and you're going to hear some pretty sobering facts around that, cognitive impairment, substance use and misuse, grief, and isolation. And those are the behavioral health care challenges that are really affecting not only the behavioral health and mental health of our senior clients, but also impacting their physical health as well. And we'll look more into that as we move forward. So first, we're going to talk about depression. So there's more than 5 million of the 34 million elders that are age 65 and older. They suffer some form of depression. And according to the APA, approximately 20% of older adults within the community suffer from depression, while approximately 50% of nursing home residents suffer from depression. And unfortunately, a lot of times there's not a lot of behavioral health interventions available in ALFs, assisted living facilities, or nursing homes. And so we have a lot of our seniors that are really suffering in a big way. They can also have anxiety disorders, and those tend to go undiagnosed as their physical illnesses mask or distract attention from the underlying or comorbidity of our behavioral health challenges for seniors. So, a lot of times, our seniors, rather than recognize that they're suffering from depression, for example, they might have somatic situations like backaches, stomach aches, headaches, and that's what they'll be reporting to their primary care physician rather than I'm feeling lonely, I'm feeling very depressed, I can't get out of bed. In fact, I'm thinking about taking my own life. So 16% of older adults displayed one or more tendencies for depression. And this is a sobering fact. Primary care physicians misdiagnosing depression in over half of the seniors that they serve. And they're 2.5 more times likely to diagnose depression in female patients over 65 than they are for males. So we've got a real dilemma here and a real opportunity to uh, do a better job, if you will, of really training our primary care physicians on how to diagnose and treat depression, what signs and symptoms to look for, both in the female and male gender. And as I said before, our mental health, we can't tease out mental health from physical well-being. We need to have an integrated approach, and we need to see how untreated mental health challenges definitely affect our physical health care and well-being. As you can see, chronically depressed seniors have an 88% higher risk of contracting cancer, as do seniors who are not depressed. And many seniors just don't know about the illness of depression or that treatment is available. So in 2021, among adults 55 and older, the highest rates of suicide were for males aged 85 and older and women aged 55 to 64. And that might really surprise you, but I can tell you that they have a very high prevalence of suicide. And the fastest growing prevalence are males aged 75 to 85 years old. And there's a myth that, well, most seniors take their own lives because they've been diagnosed with a life-threatening illness. And that is not the case. And we're going to talk a little bit more about that. The largest percent in increase in suicide rates, but in the last 20 years from 2001 to 2021, occurred in males 55 to 64 and among women 65 to 74. It used to be with our seniors that there was a real focus and higher prevalence of males, older males, taking their own lives. And now we see this real rate of older women entering that arena. Firearm related suicide, leading mechanism for suicide for males. And for women, rates of firearm related and poisoning related suicide were similar on all age groups. So let's look at this chart. People age 85 and older had the highest rates of suicide in 2022. So you can see the breakdown. Highest rates, 85, then the next highest, 75 to 84, and then 65 to 74. But then we have a higher jump, 55 to 64, and another jump, 45 to 54, and so on. So again, very concerning rates. And we need to really know how to look for signs and symptoms and make sure that our seniors are getting the appropriate treatment for their depression. Caucasian men over age 85 are the greatest risk of all age and gender race groups. A lot of people find that very hard to believe. They think it's our younger adults, but it is actually Caucasian males over age 85. And I talked about this before. Only a small percentage of folks that have taken their lives were diagnosed with a terminal illness at the time of their death. 66 to 90% have at least one psychiatric disorder. That's usually depression, followed by bipolar. And older persons are less likely to reach out by calling a crisis line than their younger counterparts. So we've got some work to do with our older adults. This is another sobering statistic. Approximately 75% of older suicide victims visited their primary care physician in the month prior to taking their own lives, and 20% of these individuals reported visiting their physician within 24 hours of taking their own lives. So we just need to do a better job of integrating behavioral health care into primary care, and we certainly are doing that with CCBHCs, with our certified community mental health centers. Lots of integration going on in our FQHCs, and that movement is really moving forward. I know the Behavioral Health Commission is really recommending that more effort is and more funding will be directed to true integrated care. Older persons tend to make fewer attempts and they use highly lethal methods. And over 50% who took their own lives used a firearm. And then you can see 12.4% on overdosing on liquids, pills, or gas, and carbon monoxide, and 24.7 suffocated themselves. So we can see in this chart, clearly the firearms are the leading cause and leading means and methods for taking our seniors' lives. So we're going to move in now to cognitive impairment, key symptoms of cognitive impairment. And I just want to say that for each of these categories that are the top categories when treating individuals that are older adults with their behavioral health care challenges, each of these categories we're going to be talking today could be a full 2 hours and then some. So I'm just going to be giving you the highlights and spur your interest for further discussion and future seminars. But the key symptoms are memory loss, language disturbance, and many presentations of language disturbance can be confabulation, calling things a different name than what it really is, word finding problems. It's on the tip of my tongue, but I can't find the word for what I'm trying to say, etc. Perseveration is a language disturbance. It's someone that you might have as a loved one that is challenged with dementia, that continually asks you the same question every 5 minutes. What time is it? You tell them. A little bit later, what time is it? What time is it? And that's called perseveration. A decline in judgment and reasoning. And that usually occurs because there's been some damage to the frontal lobe, the front part of our brains, right here. Frontal lobe disinhibition. And the frontal lobe is our executive functioning of the brain. It lets us make good decisions. It helps us reason things out. If this, then that would be the consequence kind of thing. Gives us ability to judge whether pinching a hostess at a restaurant is a good idea or not, those kinds of things. A lot of times when people have frontal lobe disinhibition, all bets are off and there's a real decline in judgment, and personality change. You might have a father that used to be a mild-mannered reporter, very calm, very cool and collected, wouldn't swear or anything like that. And suddenly there's a personality change and they become combative, they become aggressive, etc. So these are the key symptoms that you want to look for when you're dealing with seniors and you're dealing with their caregivers that are reporting these signs and symptoms. Now, one thing that a lot of people don't realize is that there's over 30 types of dementia, and many follow a very different course and progression. It's depending upon the type and the location of the brain insult. So, if you have a traumatic brain injury due to a fall or a gunshot wound, it's going to depend upon where that penetrated the brain as to what's going to manifest or what symptomology you're going to show. It's going to have a different course than if you have Alzheimer's, for example, or vascular dementia. And I want to talk a little bit about vascular dementia and Alzheimer's because we hear a lot about Alzheimer's disease, lots of money in research for Alzheimer's. People are terrified that they might be having Alzheimer's because they can't find their keys, those kind of issues. And the thing about Alzheimer's versus vascular dementia, for example, is actually vascular dementia has a very high prevalence rate in this country as well. And that has a very different set of stages and prognosis than Alzheimer's disease. Alzheimer's disease is progressive and it's fatal at this point. Lots of great research, lots of new treatments coming in, but as of today, it's progressive and it's fatal. With vascular dementia, it's stepwise. So you might have an individual that has a TIA, a little mini stroke, a transient ischemia attack, and they change their diet, they start exercising, they get on medication, and they may never have another incident of a stroke or a mini stroke. They've been following doctor's orders and they're able to stop that progression. With Alzheimer's, at the moment, there is not a stopping of the progression at this time. Korsakoff syndrome is another type of dementia, and I'm bringing that up because that is a type of dementia that comes about through alcoholism, through very heavy usage of alcohol. And that's a different type of dementia that will manifest as well. And also, dementia is often very many times, a co-occurring or concomitant condition with many medical conditions such as Parkinson's disease, multiple sclerosis, brain tumors, and head injuries. So we we need to know how the injury occurred, all sorts of different factors that we need to know about before we diagnose what is going on with an individual. And before we say, oh, it sounds like you have Alzheimer's, because to many, many people, that's worse than a death sentence. And so it's very important that if you are having your collateral family members, complaining about their loved ones, their senior loved ones, memory loss, etc., it's really important that you refer that patient to see a neuropsychologist, because a neuropsychologist will be able to do testing and be able to then give a diagnosis of what is really going on with this individual and their memory issues. And I can tell you that one of my rotations throughout my schooling was in memory disorder clinics. And we would have people come through that were diagnosed either by their PCP or another physician stating that they had Alzheimer's, which of course plummeted them into an even worse depression. And after doing the appropriate testing, there was no sign of any type of dementia at all. It was a very severe depression. And once that individual was put on antidepressants and had therapy, that memory loss component dissipated. And so it's really critical that we be careful of jumping to a conclusion of what diagnosis we may give to an individual that's struggling with memory issues, because a lot of different factors can contribute to that situation as well. All right, I'm going to move forward now with caregiver stress syndrome, because when you're dealing with seniors, and oftentimes they have not only mental health challenges, but physical health care issues and illnesses as well. Oftentimes you have one person that's typically considered the caregiver that is assigned in a family unit, if you will, the role of being the primary caregiver. And this is a very, very stressful role. I don't know if any of you have been a caregiver or are currently a caregiver. I certainly have been in my life for many, many years for three different family members. And I can tell you that it was one of the hardest things that I ever experienced. I'm grateful for that opportunity, but it was also absolutely very, very stressful and certainly impacted uh, my health. So it's a stress syndrome, okay? It's a condition that develops when individuals provide long-term care for loved ones with a chronic illness, disability, or aging-related condition. And the constant demands and responsibilities of caregiving, again, can lead to physical, emotional, and mental health problems. And some of our caregivers, these are some of the symptoms that you're going to be hearing them say that they're experiencing, and you want to ask them about as well. So, on a physical level, you can see fatigue, insomnia, headaches, gastro issues, weight changes, emotional, depression, irritability, anger, guilt, hopelessness, mental, difficulty concentrating, forgetfulness, confusion, reduced cognitive function. So it's absolutely imperative that oftentimes when we're dealing with seniors and we're very focused, as rightly so, on that senior that's experiencing issues, whether it be mental health, physical health, or both, we're so focused on them that oftentimes we forget that we really need to bring in that caregiver and do an assessment on how they're doing as well. I have a staggering statistic for you. If a caregiver is caring for someone with dementia, they are 13 times more likely to pass away before the loved one that they're caring for that's experiencing dementia. So the mortality rate is very high. Caregiver stress syndrome is very real. And so we need to be very mindful of that. You can see some of the causes here: lack of sleep, financial strain, the social isolation. Your life goes on hold or becomes non-existent as that's your primary focus in your life. There's so much grief and loss that goes along with caregiving. You're watching your loved one decline. It's very traumatic. Roles reverse, you have challenges with that, and a lot of times lack of support and resources available for you as the caregiver. Again, the effects increase risk of diseases, heart disease, cancer, etc., worsening of existing health conditions, burnout, and neglect or abuse of the care recipient. And we find that to be an often byproduct of untreated caregiver stress syndrome. So, very important indeed to address those issues. When you are dealing with seniors, this is your handy dandy community resource and referral guide that you really must have at your fingertips. And again, I mentioned before, a neuropsychologist for accurate assessment and diagnosis. It's absolutely a must, especially if there are memory concerns. You'll need a psychiatrist for medication dispensing and evaluation, a geriatrician, a medical professional that specialized in geriatric medicine. And I can't emphasize that enough as well, because geriatrics is a specialty, just like pediatrics is. For example, you would not dose up a 5-year-old with the same dosage of medication that you would a 40-year-old or an 80-year-old. So geriatric medicine takes into account all sorts of issues and changes and challenges that come with aging, including medication dosage, etc. So we must have a specialist that deals with seniors every single day, knows what those issues are, and they're experts in their field. Just like when you have a child, you want to take them to a pediatric specialist, a pediatrician, a pediatric psychiatrist, for example, because that's a specialty, children, that is in its own category, just as geriatrics are. You'll want to have a
We are good to go.
okay,
Let me
great.
know if you have control over the slides.
Let's see. Don't see it right now. I don't at the moment.
Okay. What we'll do for the time being, Dr. C, is just um, let me know now if you can control the slides.
Yes, it just
Okay.
came on.
Perfect.
Okay, here we go. So I was talking about memory disorder clinics and the community referral sources that you need to have at your fingertips, and talked a little bit about the memory disorder clinics and the fact that over 50% of the people that we evaluated really did not have any form of dementia. It was severe um, depression. And once they were on medication and received the appropriate treatment, all the memory fog lifted. And other required specialists as well that you'd want to have, family therapist, etc. All right. So we're going to move into prescription drug use and misuse. And memory issues certainly play a part of this. We'll talk a little bit about this, and other things factor in as well. So, according to the National Council on Aging, 25 to 40% of the older adults in this country use prescription drugs and they fill an average of 15 prescriptions per year and often take up to 10 different prescriptions at one time. So you can see that if they don't have doctors, their cardiologist is not coordinating with the PCP, who's not coordinating with their neurologist, who's not coordinating with their cardiologist, you can see that a lot of times these drugs that were indeed prescribed by a physician, unfortunately, many of them may have interactive effects and negative effects. And because our system of care is not fully integrated as we'd like it to be, oftentimes one doctor has no idea what another doctor is prescribing, etc. So this can wreak havoc on our seniors. It's estimated that 85% of older adults take at least one prescription drug daily, and 76% use more than one daily. 70% also use over-the-counter drugs daily, and those have some unique challenges, or can have a unique challenge as well. And 21% of hospitalized adults over the age of 40 have a diagnosis of alcoholism, with related hospital cost as much as 60 billion a year. So when we see that we have an alcohol problem coupled with using prescription drugs, and we know that our seniors often have alcoholism, it's a recipe for disaster, frankly. Now, why do our seniors misuse their prescription medication? Well, it's their own well-intentioned non-compliance. Could be a financial issue. Well, I know I'm supposed to take this medication until my symptoms cease. I know I'm supposed to be on it for 2 weeks, but it's been 1 week and I'm feeling good. And if I get the flu again, I'll just use the remaining pills to treat that another bout of flu. Um, or it's a physician prescribing too high a dose. Again, that's why it's so critical to have a geriatrician dosing up seniors. You don't give the same dose of a medication to an 80-year-old as you do a 40-year-old. So oftentimes physicians, it not meaning to do something incorrectly, but they are so used to, dosing up their average age in their own practice that perhaps they are not aware of the different issues that face our seniors. We talked about the lack of physician coordination of medications. Financial constraints. We have a lot of seniors that have to decide whether they're going to eat or they're going to get their prescription refilled. And that's a very sad state of affairs, but it's a reality that many of our seniors face. Also, cognitive impairment or some memory issues. So the senior says, they take their medication in the morning, they're going about doing some chores, and they stop and think, did I take my morning medications? I don't think I did. And so they go back and they take them again. And, sometimes they forget and they take them again. And so you can see where there is a real danger for our seniors to misuse their prescription medication. So we talked about alcoholism in older adults. Widowers over the age of 75 have the highest rate of alcoholism in the United States. Nearly 50% of nursing home residents have alcohol-related problems. And if you aren't really familiar with the nursing home environment or the populations, etc., oftentimes our assisted living facilities and our nursing homes have happy hours. And the ageism creeps in when they're confronted, if you will, with, gee, a lot of these seniors are taking a lot of prescription medications, and drinking on top of that is not a good idea. Or you have some residents here that have real alcoholism issues, and you're promoting this happy hour, and oftentimes the nursing homes, again, They want their residents to be happy. They want them not to isolate in their rooms. They feel like this is a good thing to have, a social, and they can get together and etc. And this can be a recipe for disaster because again, alcoholism is very prevalent with our seniors and is fraught with lots of issues. And you often hear people say, and again with ageism, oh well, hey, Bill is 78 years old, and he's he drank scotch all his life and he still drinks scotch. What are you going to deny him that? He likes his scotch. And so not really realizing that um, Bill needs treatment and Bill is dancing with trouble here with his prescription drug medications and also other issues that can occur as a result of his untreated alcoholism. So, um, also another issue that a lot of people don't know about is older adults are hospitalized as often for alcoholism as they are for heart attacks. And they're also hospitalized for falls, which can be traced back to their alcoholism. And then they sustain a head injury or they break their hip or what have you. So there's all sorts of issues that can occur with seniors that have a problem with alcoholism. And so what other people believe too, some people I should say believe is that well, they're too old now, but to put them into treatment now, that's a losing proposition, and it is not. In fact, seniors, when they trust you and they trust your organization or they trust you as a clinician, they're more compliant and have better outcomes than any other age cohort. So the old adage, you can't teach an old dog new tricks, or they're too old, or oh, just let them be, is a myth because older people can and do enter recovery in their senior years, and their health can totally turn around as a result. And again, there's lots of literature on what does sensible drinking mean for older adults. The NIAA states that for over 65 means no more than one alcoholic drink a day, and some would argue that that's too many. Lots of research now, and I'm sure you've probably read about it, that they're linking alcohol consumption with cancer, high rates of cancer. So lots of study on this and lots of health negative consequences. So we don't want to forget that our seniors can benefit from treatment for their alcoholism and other drug addiction. A lot of our seniors also are addicted to marijuana. They smoke marijuana, take other drugs, opioids, etc., painkillers, get addicted to those because of past injuries or current injuries. So a lot of work that we need to really delve into when we're dealing with seniors and addiction. According to the National Council on Alcoholism and Drug Dependency, 14% of elderly emergency admissions and 20% of elderly psychiatric hospital admissions are a result of alcohol or drug problems. And I venture to say that's maybe not really as high as it really is. So we've got to be mindful. A lot of times when a senior comes into the ER, for example, for a fall, they're focused on, and rightly so, uh, the current issue, a broken hip, a broken leg, etc. And they're not thinking about doing an evaluation for the seniors' potential addictions. What made them fall in the first place? They're very focused on let's fix what happened here when this person fell. Let's send him to surgery. Let's stitch him up, whatever it is. All right, our next topic that we're going to tackle is seniors and grieving. And bereaved older individuals, they rate their health as poor. They experience increased rates of hospitalization, and they're 8 times more at risk for death. And grieving, I tell you, as we age, and the statistics certainly back this, research backs it. Most of the time, as we grow older, our losses grow more. And that doesn't necessarily mean loss through death. It can be losses that we are grieving for other things, such as loss of mobility. Perhaps you've been very, very active your entire life, and suddenly you find yourself, for whatever reason, on a walker or a wheelchair and not able to ambulate as you once were able to. Retirement. Uh, for a lot of people, they think, oh boy, I'm going to retire and live the life of Riley. I'm going to golf every day. I'm going to have fun. I'm going to travel. And then something happens and they're not able to fulfill those goals, those dreams, those wishes. And also with retirement comes loss of identity. So they're grieving, oh, wow. I was just on a call with a former CEO, actually, in the course of the conversation, and it was a group call, and he said, "Oh, I'm a nobody now. I'm retired." And so that loss of identity is certainly something that many of our seniors grieve. They also grieve that they think, oh boy, I'm living in Michigan now and I'm going to move to Florida where it's sunny 360 days of the year. And, again, I'm going to be swimming and fishing and this and that. But they don't realize that they're leaving their home that perhaps they lived in for 50 years in Michigan. They're going to be missing their neighbors. They're going to be missing their former work colleagues. They're going to be missing their church uh, friends, etc. And so all these things up for seniors that grieve. Oftentimes, through death, you'll hear seniors say, I've gone to a funeral every month this year. I kept my black dress or my black suit hanging pressed and ready because that's all I feel like I'm doing is going to friends and loved ones' funerals. So lots of grief in this population in particular. And there's a great book that I highly recommend if you haven't read it. It's kind of an oldie but a goodie, and it's called Necessary Losses. Necessary Losses by Judith Vorst. And I believe you spell her name Virost or Vriost, Judith Vorst. And she talks about the different things that we grieve over, not just someone's death, but some of the things that I talked about earlier. And what we know about unresolved grief issues is that, thank you so much. Someone put that in the chat. Unresolved grief issues, it's cumulative. And if you have not fully grieved or you've stuffed your feelings down, you'll hear your senior clients say something like this. I'm here and I'm grieving the loss of my husband. However, I'm just plagued with nightmares and thoughts of my grandmother's funeral, which was 50 years ago, or the loss when my family moved and it was so traumatic for me. And I'm thinking about all these losses that I've accumulated. And I think I'm going crazy because shouldn't I be just focused on, this latest grief? But no, I'm so heavy and weighed down and burdened by everything that's flooding in my mind now about all these other losses that I've had in my life. And so you must be really cognizant of that and normalize that, because what it's telling you as a clinician is they have a lot of unresolved grief and loss issues. And those unresolved grief and loss issues don't go anywhere. In fact, we remember traumatic events, and trauma is stored in our body on a cellular level, and it can wreak havoc with our physical health care. That's why, hence, 8 times more at risk for death. So it's really important that you understand how devastating loss can be for a senior and how important it is to provide them with good grief counseling so that they can, it doesn't mean they're going to forget what happened or forget their loved one, but it just allows them to give sacred space for them to process not only the current loss that they've experienced, but other losses throughout their life. Does that make sense? Okay. Yeah, we're getting some great comments in the chat as we speak. So let's look at some of the other things that can cause grief. We've talked about loss of identity, the loss of stature, the loss of a daily routine. When you work, you have a purpose. You get up, you have a routine, you brush your teeth, you take a shower, you have to be at work at 8:30. And all that goes out the window with retirement, doesn't it? Unless you establish a new routine, which is very important when we're counseling our seniors. The camaraderie with colleagues, also the loss of a beloved pet. Now, for some of you all, I know you're pet lovers. I'm a pet lover. It's devastating. Some people that might not, have that same kind of attachment to pets, it might be difficult for you to understand that, that cat or that dog or the bird or whatever pet that senior loved and cherished is absolutely devastating to them. Oftentimes, that pet is the only companion and the only reason the senior gets up in the morning to take the dog for a walk or to feed Fluffy or to pet for tactile stimulation a pet and to receive the love back. So don't diminish when a senior comes in and is very, very devastated on the loss of a pet. Also, we talked about the loss of health or physical abilities. I mean, when you have a health crisis, one day you're going 90 miles an hour and feeling great and having lots of energy. And the next day, boom, you're having heart issues and you're exhausted and you're not yourself. That's a real shock to the system and a real loss to you to muddle through and to grieve and to get some help and support. So seniors and grieving, why don't seniors come forward when they are grieving? Well, a lot of our seniors, especially the great generation, the World War II generation, that, were told you don't air your dirty laundry, pull up your bootstraps and get over it, pull up your big girl panties and deal with it. All those comments. Um, they were taught you're just strong, you just suck it up, particularly males in that generation. I mean, they were punished for crying. Big boys don't cry, for example. Um, so it's really hard for some of our seniors to come forward and admit that they're having some behavioral health care challenges. And so that's why oftentimes they're very comfortable coming in and saying, I've got the terrible headaches and backaches and stomach aches and muscle aches. And then they go through tens of tests, comes forward that's positive in any way physically. And they're just somatic complaints. And you want to think about, wow, I wonder what they're challenged with behavioral health. A lot of our seniors think it's a weakness to seek help. A lot of them don't even understand that they have a problem with alcohol or mental health issues. Their generation, the three martini cocktails at lunch was standard operating procedure. I mean, they had bars in their offices, and it just, you got home, you had a bad day, and you had a couple of drinks. So it was very accepted and part of the social scene and part of their culture, for instance, to drink. And so they don't even understand that they might be having a problem with it, or mental health issues. They don't understand what depression looks like, what some of those signs and symptoms are, and so on. So they don't recognize that they might be experiencing them themselves. Oftentimes, our seniors are isolated. They have limited transportation options. And so one thing that COVID, the silver lining of COVID, was for all of us is it allowed us to shift very quickly to make sure our populations, our clients, were continuing the treatment that they needed via telehealth. And now with the in-home on-site, uh, some of the types of programs we have, or the mobile response teams that can go to someone's home when they're experiencing a crisis. So we've come a long way and very grateful for that. Again, research shows that older adults who seek professional help have very high success rates for improved emotional and physical health. So again, that myth that, oh, they're just too old and set in their ways, et cetera, is a myth. They have the best outcomes, frankly, of all age cohorts. So we want to be sure that we know that, and we want to give them the treatment and the resources that they so richly deserve. So you may hear that we are in this country, and the Surgeon General agrees, we are experiencing a loneliness epidemic, and it's getting worse by the day. And there's so many different reasons why we in this country in particular are experiencing this. The advent of social media right at your fingertips and communicating via text versus picking up the phone or visiting a neighbor or a friend. And the again, the reduced mobility for a lot of our seniors, so they can't get out and go play cards anymore, or meet their friends for lunch, or go play bridge, or whatever it is. And so they're increasingly isolated and lonely. It used to be that, and I'm sure many of you can relate to this, that a lot of people, wherever they were born, they lived there their entire lives and they died in that same town. Well, with our very mobile situation here in the United States, where we leave our hometown and we go for other jobs in other states, and we leave our family, we leave our friends, and we hop around and we move from state to state, whatever. I mean, it's not the same cohesive type of atmosphere that we had once before. And I'm not saying it's good, bad, right, or wrong. I'm just saying a lot of these issues have contributed to this loneliness epidemic. You've probably seen the statistic. Increased risk for premature death when you're lonely is comparable to smoking 15 cigarettes a day to your physical health. 29% increased risk of heart disease. 32% increased risk of stroke, and 50% increased risk of developing dementia. Not a lot of stimulation when you're sitting in your home alone 24 hours a day, 7 days a week. And in the cardiac world, they now have a syndrome for heart disease called broken heart syndrome. And a lot of times you'll hear that, particularly spouses that have been married for, a long time, 50, 60 years, and one spouse dies, very soon thereafter, the other spouse dies, oftentimes with a heart-related issue, and they're diagnosed with broken heart syndrome. So this is a real phenomena. It's a real disorder. And we have to be very mindful of the very negative effects that it has both on our mental health and our physical health for not only seniors, but our other populations that are reporting feeling very lonely, feeling very isolated, etc. And I see some of the chat. My grandmother passed on in 2018 from broken heart syndrome. Yes, yes. So it's a real thing. And if you think about it holistically, mind, body, spirit, you really can't tease out one from the other, can we? Such an integrated system we have as human beings. And when one area is affected, we're lonely, broken heart, we're grieving, we're depressed. It's definitely going to affect our physical healthcare and vice versa. So, very good to remember. Um, so let's talk a little bit now about what are some of the risks and barriers to treatment. Well, the normalization of substance misuse in living settings. We talked about that in ALFs, in nursing homes. It's happy hour. Well, Joe drinks in his room. We don't care. Joe has done this. His daughter reports that he's, began drinking when he was 14 and he just hasn't stopped. And whatever Joe wants, we're not going to interfere. The social isolation and lack of support systems. Um, our seniors, again, we talked about the inability for mobility for many of them. Some of them can't hear, so or have poor hearing, and that's very isolating because if you can't hear what somebody's chatting to you about and you can't engage in conversations because people get annoyed when you keep asking them, what did you say? Or you're saying, what did you say? Can you repeat that? And they're screaming at you and getting annoyed and frowning at you. Then you just learn to just, back off, shut up, and disengage. Lack of support for our seniors. We don't have a lot of specialized programs for seniors. We have a lot of children's programs for seniors. We have CAT teams and FIT teams and programs for child welfare and SIP programs and treatment facilities for our kids. But we don't have a lot for our seniors. And by the way, treatment for seniors, they need to be in a all senior facility. That's why it was so counterproductive when they were being allowed to be Baker acted, okay, in CSUs when they were rooming with a 30-year-old person with crack addiction. They couldn't relate. It was like two different universes. It was not helpful. When they were in group therapy, it was like they were on Mars. And thankfully now you cannot Baker Act a senior, particularly one with dementia, but they deserve their own geropsych unit where they're with other seniors that they can relate to. And they have a geriatrician and a geriatric neuropsychologist and others that are trained to help them. we have a lot of providers that well-meaning and they do fabulous, fabulous work. But a lot of times they did not get any training in their social work degree or their doctoral degree, for example, um, on how to treat seniors, older adults. So they don't know. They don't know what they don't know. And so I think that we need to do a much better job of having more trainings like this and being able to really emphasize the need for every clinician to have this knowledge because, my God, we're having 70 million older adults in this country, 1 out of 5 now. We must know how to treat them. And poorly coordinated care. We have that fragmentation in our healthcare systems. Nobody's fault. Everybody's doing the best that they can. But again, when one provider is not in contact with another, let's talk about medication, and you're prescribing maybe the same medication, maybe you're prescribing the same at a different dosage, maybe you're prescribing medication that totally is contraindicative to another medication that this patient's taking, but you don't know. So the care needs to be better coordinated for seniors. Also, let's see, ambivalence about change. People are, we're creatures of habit and we don't like change, frankly. And that's just kind of something that we all grapple with. Some of us are more malleable to change than others. Some of us are more flexible than others. But there's a lot of ambivalence about changing the system the way it is and the way things have always been done. And so it's a real culture change. And for any of you that are familiar with change management and have tried to change culture in your organization, you know that there's a lot of pushback initially, or there can be, because people don't like change. Um, Also, risks and barriers to treatment with all the life changes and losses. Sometimes people, our seniors, just feel, what's the use? I'm overwhelmed. I'm too exhausted. I feel too hopeless. I'm at the end of my rope, and hence the very high suicide rate, I might add, because of all these life changes and losses that they've had to incur. And again, the different signs and symptoms of behavioral health challenges that go under-recognized or unrecognized by providers. They focus on the physical somatic symptoms, for example, or they don't have a depression screening in their PCP practice, which is changing rapidly, I'm pleased to say. But they don't, it's not in their wheelhouse, it's not what they've been trained to do. So I think we have a great opportunity to make some needed changes in our system of care, to have more trainings, to have more recognition of what seniors struggle with. And I think that our system will really grow and expand, and I think more seniors will be helped as a result. So, what are some of our approaches that we want to think about to address our risks and barriers? Well, let's use age-sensitive screening and brief interventions. Okay? We want to be sure that they are user-friendly for our seniors and they're age-appropriate. Tailor treatment to our older adults' needs. Again, best treatment is to have older adults together in the same facility, the same treatment setting, so that they can best relate and understand and gain some great knowledge as a result. We need to integrate our healthcare and treatment planning to make sure that someone's not slipping through the cracks, or we unintentionally are causing the senior to misuse their medications. We want to leverage the motivational counseling and client-centered engagement. A lot of times when we're in a hurry and we've got a senior client and we've got, let's say, their spouse coming in with them or their daughter or son, and we start doing an intake and we can see that the senior is slow to respond, etc., which is called long latency, which is a big red flag for some kind of vascular issue going on. Okay. But the daughter jumps in and says, "Oh, he was born in, 1945, and yes, he lives alone." And she's answering all the questions you're asking. You're missing a lot of information by not saying, "Thank you so much, Mary, for being here. What a great daughter you are. But I'd like to hear from Mr. Jones, your dad. Mr. Jones, can you answer these questions for me?" So that you can hear those language anomalies, see him struggling with word finding problems, um, see him maybe tear up or get very upset when he's talking about his wife's death. These are all signs that if you continued allowing the daughter to just go rapid fire, answer the questions, you're missing his input. And frankly, he kind of feels invisible, like he's really not in the room because his daughter's taking over and answering all the questions for him. So really, really important to think about that. And we need to train staff in geriatric focused care, what signs and symptoms to look for, and how to work with an older adult. And if they are, for example, with frontal lobe disinhibition, I told you that oftentimes our seniors are doing very inappropriate things and saying inappropriate things as well. And so they might blurt out, they might start swearing at you or commenting on some body features of yours. And you get very turned off and, you know, I don't want to even meet with him again. We need to understand those are clues. That's grist for your mill. You need to be thinking frontal lobe disinhibition. I mean, this gentleman obviously, has said some very inappropriate things, but that tells you that he needs a neuropsych evaluation because something may be going on at the frontal lobe stage for him. And we need to offer flexible treatment settings, geropsych units, drop-in centers for seniors, in-home on-site programs for seniors that can't get out, transportation for our seniors to get them to join a senior center, get involved in activities from 10 to 2 every day so they're not isolating. So those kinds of things that we want to think about when we're dealing with our older adults. So I know I've covered so much in a short period of time, that we went over the key behavioral health care challenges that our seniors grapple with. And I know that there probably are a lot of questions or comments in the chat. So I'm going to turn it back over to Robert and we can have a dialogue.
Perfect. Thank you, Dr. C. I know we have a few questions that have come through during the webinar, and if you have additional questions, please put them in the chat. We'll get to those in just a moment. The first question is, as of 2021, there were approximately 7,500 board certified geriatricians in the United States, but only 418 in the state of Florida. This person acknowledged that we don't have enough to go around. So what do we recommend for older adults who don't have a geriatrician in their area, or the ones who are present but aren't taking new patients?
Right. And that's such a great question. And I actually, it was interesting when I was doing my rotations up at, Harvard Medical School. I was in charge or assigned to treat medical residents, and they were rotating through the neuropsych uh, rotation with us, dealing with patients and geriatric patients and so on. It was amazing to me to see the comments from a lot of these residents that were very turned off by even wanting to think about going into geriatrics. Comments like, I don't want to deal with these people. They're too slow. They smell. I mean, it was shocking to me. Um, and so what medical schools are doing now with that very disturbing statistic that you brought up is that they are offering full rides for medical, and some medical schools are doing this for residents that are willing to specialize in geriatric medicine because there's so few that are willing to do that. They're more interested in the higher paid, ortho and plastics and other specialties in medicine than geriatrics. So it is a systemic issue. We need to do more of that to encourage people to enter the field. And it's also systemic with the reimbursement rates, for example, for Medicare. I mean, I know here in Jacksonville at the Mayo Clinic and the Mayo Hospital, where people come in from all over the world, they have stopped taking Medicare for payment. And uh, I couldn't believe it. And it's because they have notoriously lower rates for reimbursement than your Blue Cross Blue Shields and other payor sources. So lots of work systemically that we need to do. And as far as working with a senior that there aren't any geriatricians in your area, I would look for perhaps some ARNPs. I know real movement to give more power and authority to uh, advanced registered nurse practitioners, and many of them have a specialty in geriatrics. I would try to find a neuropsychologist that, even though your senior might not be exhibiting any signs of memory loss, so they really don't need a neuropsychologist at this time, contact that neuropsychologist because that neuropsychologist will know the various resources, the various clinicians and physicians in your area that may be working with seniors or have great outcomes and a great passion for them that you may not be aware of. You can also contact your senior resource centers. The agency, no, what are they called? Let's see. I'm thinking of agency. There's one in every county. Agents for adults, Senior Resource Alliance. Very good. Thank you, Rhonda. Um, and you can call that phone number and ask for resources for your particular community. Area Agency on Aging. That's what I was trying to find. Speaking of word finding problems.
Thank you so much. Somebody asked, are there examples of national organizations where grief-informed approaches, including pet loss grief, have been formally integrated into senior behavioral health or social isolation interventions?
Yeah, that's a great question. And certainly, I know SAMHSA has a great library of on that topic. I know that National Council for it used to be behavioral health, now it's for mental health well-being. They have a lot of literature on that topic. Hospice also is a very good organization that have specialized counselors, as you can imagine, that specialize in grief and loss and have support groups and grief counselors that you can tap into. So, yes, to that question, for sure. There are formalized evidence-based programs and practices and protocols that you can uh, avail yourself of.
Awesome. The next question is, it's my understanding that physicians can check the PDMP, which shows all current active prescriptions. Do you feel that as a whole they take the time to do this, or is it unrealistic for most practicing physicians and prescribing doctors?
I think it depends. In the world of managed care, where you know, physicians are expected to see, everybody within a 15-minute window and one right after the other, and some of them have quotas depending upon what their contract is, for how many they need to see, etc. Sometimes they certainly don't mean to be unintentional, but oftentimes the time constraints interfere with that. Or they might review it, but it might be after they've already seen the patient and the patient's gone home. So it just depends. It just depends upon the office management, the office protocols, and that kind of thing. But yes, there is that they can tap into that. Absolutely.
Perfect. And then the last question I have so far, and a few people have asked this question, can you recommend screening tools that we can use with our senior caregiving patients to identify some of the symptoms we've talked about?
Yes. So there is a resource for caregivers. There are brief uh, evaluations. I don't have that at the tip of my tongue right now, but you can get on the Caregiver Alliance website. They have screening tools. I believe you can also pull from American Psychological Association. They have a network and a division, particularly for seniors, and have those resources. I think SAMHSA tools and tips are good. See, Kate has put something in the chat. Yes, APA, good. Caregivers practice settings, assessments, tools. Thank you. Um, so yes, we have those screenings, and some of the screenings that we use for very quick screenings are one is a clock drawing to see if we feel like there might be some dementia. And you ask a client to draw a clock, make it read 10 after 10, and it's very interesting to see some of the clocks that are drawn. Um, some of the clocks are all one-sided and nothing on the other side of the clock. That tells you that there's something going on with either the left side or right side of the brain. Um, so that's a down and dirty. Um, the Some of the other ones, let's see. I use There's a it's geriatric brief screening. Um, that's that's a good one. You don't have to be a neuropsychologist to administer that. Kate says Mocha is great. Anyone else have any suggestions? 3 words to remember, yes, through your visit, and then you deliver them at the end of the session. Yep. Okay, Kate's giving another wonderful website, mochacognition.com.
And while people are typing in the chat, a new question came in that said the percentage of seniors being charged with DUI, and DUI property damage is rising in Florida. Curious if this has been correlated with those seniors who are feeling widowed or isolated.
That's a great question. I know it's certainly been correlated with their high prevalence for alcoholism, et cetera, but I'm not sure whether they have done a deep dive to see if it was this person a widow or widower. Um, yeah, Sabra says many senior DUIs might involve their meds. Many oftentimes have that concomitant memory issues and their judgment and reflexes, etc., have been affected, either with mini strokes or whatever they might be struggling with in the memory loss arena. Sometimes their perception um, is affected as well.
Perfect. I do see a question that says, what is the percentage of seniors who pass away shortly after their partner?
Mm. I don't have that handy, but I think we'll find that it's a pretty high percentage rate. And what I can do is do some research on that and get back with y'all. I don't have that handy right now.
I think that's all the questions that I have seen. I do want to give it another minute. If you have any questions or if I missed a question somewhere in the chat, please feel free to put it in the chat. I do see that a comment just came in. The widowhood effect has been found among men and women of all ages throughout the world. Recent longitudinal studies put the excess mortality of widowhood compared with marriage among the elderly between 30 and 90% in the first 3 months and around
Mm,
50% in the months thereafter. So thank you for that. And this
absolutely. Thank
the
you.
citation is posted there as well.
Yeah.
Any other questions? Anything that I've missed? Any other questions come to mind? Give it just another minute or so.
And while people are thinking, I was just going to comment on that. That's why it's so important. A lot of times, our one of our parents passes, and and everybody's there for the funeral, everybody flies in, they're there, maybe stay for a week later, and then all of the kids, the adult kids, live elsewhere, they fly back to their homes, and that widow or widower is left all alone, isolating, grieving. We know the very devastating effects of that on their health. And so it's really important that we shore up the support and shore up the communication with that individual that's been left behind, um, and check in and get them involved and stay connected because of that staggering statistic that again, falls into the broken heart syndrome, loneliness epidemic, isolation, disconnection, etc. So a lot of support groups for our seniors that you can refer them to. Let's say there has been a death of a spouse. There are support groups that they can join that other people in the group have lost a spouse. Very helpful. Very, very good for them to be able to process their feelings with other folks that know what they're going through and are experiencing the same myriad of feelings.
Thank you so much. And I do want to throw out one last thing that I'll say before we get to the conclusion. We did a webinar on senior issues a few months ago as well, and there was a statistic in that webinar. If you reach out to me, I can provide it, that pointed out that seniors who develop communication skills and have social support prior to their spouse passing are more likely to demonstrate resilience after the fact, as opposed to those who are already isolated. So that's just an interesting tidbit about that resiliency. But with that, I don't see any more questions. So I'm going to take it over and go through the conclusion. I want to say there are some references and resources as well in the PowerPoint PDF that you received. If you have any questions, Dr. Caufield's email is here on the screen. I'll
Yes.
also go over FATA email here in just a moment. But I want to thank you all for being here. Thank you, Dr. Cauffield, for the wonderful information. Thank you all for bearing with us with the technical difficulties we experienced. But please hang tight for just a moment for a couple of closing business items. First, with the evaluation will automatically populate when I end the webinar here in just a moment. You will also receive an email with the evaluation link in 24 hours. As a reminder, the evaluation deadline is March 4th, 2026. If you have any questions, please feel free to email us at training@floridabha.org. Certificates will be emailed to the email address associated with your attendance within 30 business days. CEUs will also be reported to CE Broker within the same time frame. As a reminder, you must have attended the entire webinar and completed the evaluation. We are not permitted to provide partial credit. The recording and materials used in today's presentation will be available on the FATA website within 30 business days. To access the recording in PowerPoint, visit www.fata.org, navigate to the Resource Center, and click on the training library as shown on the screen. And I did just see a question in the chat just real quick that said about future webinars. If you would like to be on the email list for future webinars, you can go to www.fata.org, navigate to the events tab at the top of the screen and click on upcoming training. There will be a little box on the right hand side of that screen that says click here to be added to our mailing list, and you will get emails regarding our future webinars. With that, thank you everyone for participating in today's webinar. We'd like to recognize and thank Dr. C for her time and the wonderful information. We'd also like to recognize and thank the Florida Department of Children and Families for funding today's education. Have a great day, everyone. Have a great weekend, and please hold for the evaluation.
Thank you so much.